And now it's recording. Right, welcome to Psychopharmacology for the summer 2024. Professor Richard Collado. What about Peter Smith? He's not here this semester, but he's kept the same one. All right. So the neuron is really what we're going to focus on, right? So neuron is the functional unit of the brain. So, obviously the first lecture, we're going to focus on some neuroanatomy, neurophysiology, specific stuff. You don't have to memorize everything, but just understand that the neuron is the functional unit of the brain. All right. You have the dendrites, the cell membrane, the soma, all right? Axon terminal. So remember, action potentials kind of work their way down from a presynaptic neuron. That would be considered an electric, transmission, and it goes to a chemical neurotransmission. So chemical neurotransmission is really what we focus on in this course. So it would be neurotransmitters, right? So you would have to understand what dopamine does, serotonin, norepinephrine, acetylcholine, histamine, just to name a few, all right? This is what I was talking about before, synaptic neurotransmission. So you have the presynaptic neuron, which is on top, all right? Really understand what reuptake is. So reuptake is the way the body kind of recycles neurotransmitters, all right? Because obviously it would be more wasteful if you had to create new ones all the time from scratch. You actually need to recycle the other ones. So a lot of our medications for depression, anxiety, we call them reuptake pump inhibitors, right? Because if you inhibit the reuptake pumps, what's going to happen is it's not going to suck up those neurotransmitters, and in essence, you're actually going to increase the amount of neurotransmitters there, right? So if you look at that reuptake pump right there in the middle, that's what recycles dopamine, serotonin, norepinephrine. Some parts of the brain have a specific amount of reuptake pumps. For instance, the dorsolateral prefrontal cortex, the frontal lobe of the brain, doesn't have a lot of dopamine transport pumps. So by actually inhibiting norepinephrine transport pumps, it would actually increase dopamine in the frontal lobe, right? When we talk about ADHD, impulsive behaviors, that's what class of meds we're going to be using, right? They're going to increase dopamine. They might work on dopamine reuptake pumps, similar to, I don't know, Adderall that you guys know, or Ritalin you might have heard of. Vesicles are also important because there's two parts to that, right? So you have the reuptake pumps who are kind of like outside, extrasynaptic, right? And then when it sucks up the neurotransmitters, it's going to go inside the cell and it goes inside the cytoplasm, right? When I talk about cell, I'm actually talking about the neuron. And you have vesicles inside the neuron, which actually help with recycling, right? We call those VMATs, vesicular monoamine transporters that go inside. Once they go inside the vesicle, that's technically when they're recycled. So there are some class of meds that work on that vesicle that if the medicine goes inside from the reuptake pump, it doesn't go inside the vesicle, it's not safe and actually gets eaten up by monoamine oxidase, right? You guys have heard of MAOI inhibitors. We use them for depression a lot. So anything that stops MAOI would actually increase the amount of those neurotransmitters that need to be broken down, right? So once again, reuptake pumps are very important, right? Because we have a class of medications called SERT, or serotonin reuptake pump inhibitors, NET, norepinephrine pump inhibitors, and we have DAT, dopamine transport pump inhibitors, would actually increase the amount of neurotransmitters that stay inside that cleft between the presynaptic neuron and the postsynaptic neuron, and that's how the medications work. All right, so by stopping the reuptake pump, you're actually keeping those neurotransmitters in the cleft more, and it's actually going to work in the postsynaptic neuron even more, right? Whether it's going to alleviate anxiety, alleviate depression, whatever it is, all right? The vesicles are important because just because it goes inside the neuron, if it doesn't go inside the vesicle, it gets eaten up by monoamine oxidase. So technically, it would actually decrease the amount of norepinephrine, dopamine, serotonin, or whatever, right? We have the receptors, right? We're really going to focus a lot on receptors. I know right now it might seem like a new language, but I really want you guys to understand the language of pharmacology, neuropharmacology, all right? Psychopharmacology, all right? So we're going to talk a lot about serotonin receptors, right? There's actually a lot of them. I believe last time I checked, it was like 18 of them. They're finding new ones all the time. So serotonin receptors are classified as 5-HT. So if you look in the book, 5-HT is the same as serotonin, right? I can say serotonin 2A receptor, or I can say 5-HT2A receptor. It's really up to you guys. I'll probably use both, all right? I can say serotonin 1A receptor, or I can say 5-HT 1A receptor, all right? Notice just because it's a serotonin receptor, if it's actually presynaptic or postsynaptic, it might do different things, right? We're really going to focus on that a little bit later on, but where it's placed anatomically is also very important. So if something's postsynaptic, right, it might do one thing. If it's presynaptic, it might be an autoreceptor. Anyone know what an autoreceptor is? If it's presynaptic, what would an autoreceptor do? You can take a guess, it's fine. It regulates the release, all right? So let's say, for instance, to have a serotonin receptor on the presynaptic neuron, it has a negative feedback loop. So what happens is the presynaptic neuron is going to spit out serotonin, right? Whatever it is, whether I'm thinking or I'm talking to you guys, my brain is working, right? After a while, enough serotonin accumulates, it's going to go to the presynaptic serotonin receptor, which is an autoreceptor. That tells it to shut off. What happens if you don't have receptors in the presynaptic neuron? What can happen? What do you think happens if it doesn't shut off? You can have epilepsy, right? You can have a seizure. You can have excitotoxicity, right? Excitotoxicity means that you're overstimulating that postsynaptic neuron and the person's overstimulated, right? Sometimes it can manifest as psychosis. Sometimes it might happen as a seizure. Sometimes they might cause, I don't know, increased anxiety with norepinephrine, right? Fight or flight response. You're flooding your norepinephrine receptors with norepinephrine, right? Which is increasing your blood pressure, heart rate, and so forth. Okay. So really understand reuptake pumps, understand diffusion, right? Going from high concentration, low concentration. And degradation is really the vesicles. The vesicles are what degrade it, right? It breaks it down and it gets recycled again. So if it doesn't get inside the vesicle, it doesn't actually get recycled. So that's degradation, all right? Degradation is also, C. You have monoamine oxidase, which is inside the cell, and you have something called COMT, which is called cathyl O methyltransferase, which eats up the neurotransmitters outside. All right. Any questions? Well, types of neurotransmission. All right. So most neurotransmission is anterograde, which is what I was talking about before. Right. Anterograde means it goes from the presynaptic neuron to the post. All right. So it usually goes from left to right. That's usually how they show it in the tables in the books. Left to right. Anterograde, right? From the presynaptic neuron to postsynaptic neuron. Retrograde means that the postsynaptic neuron also communicates with the presynaptic neuron, all right? Sometimes it could be to innervate that autoreceptor, like I was talking about, right? The postsynaptic neuron is getting stimulated too much. It's going to release a chemical, which will bind to the presynaptic receptor, which will tell it to say, hey, there's too much stimulation. Please shut me down, all right? Remember, your body has to be in homeostasis and it has to balance out. There can't be too much, so it kind of balances by having that shut off valve, all right? Retrograde neurotransmitter, some examples are, anyone know? Have you guys read up in the book? What are some examples they use in the book of retrograde neurotransmission? Growth factors, right? NGF. Sometimes the postsynaptic neuron is going to talk to the presynaptic neuron to tell it to grow, right? Or increase in its synapses or increase in its amount of receptors, right? It's called NGF, nerve growth factor. Another example is nitric oxide, right? Which causes vasodilation. Another example, I believe they use in the book, is endocannabinoids, all right? So technically, when someone smokes weed, marijuana, that also sometimes works in retrograde neurotransmission from the postsynaptic neuron to presynaptic neuron, all right? Volume neurotransmission, like an example for that is in ADHD, in which, like I mentioned, there's actually none, I believe, dopamine reuptake pumps in the frontal lobe, all right, or very little. So what happens is the net pump, which is norepinephrine reuptake pump, is actually what sucks up dopamine. So by giving someone a drug that also works on norepinephrine transporter, it's actually going to increase dopamine, and that works through volume neurotransmission. So the presynaptic neuron will actually secrete dopamine, and since there's not a lot of dopamine transport pumps there, it's going to flow to the frontal lobe a little bit more, and it's going to be volume. Think of like a cell phone connection, all right? So not just from me to you, who's next to me, but it might go, I can call someone who's, I don't know, down the room or something, all right? So it's volume. It goes out and it spurts, all right? So you get a flood of dopamine. There's not a lot of dopamine reuptake pumps there, so dopamine tends to linger a little bit more, and it'll bind to receptors in a distant neuron, all right? Not just the neuron that's next to it, but a distant neuron, which could be further away, all right? Any questions with that? Anterograde goes from a presynaptic neuron to a postsynaptic neuron, which is called classical neurotransmission. Retrograde means that the postsynaptic neuron is actually communicating back, all right? That could be, hey, shut off transmission because you're stimulating me too much. It could be nerve growth factors telling them to, increase connections. If, let's say, when you're learning in the hippocampus, right, the learning center of your brain, you might sprout out new connections, and that might be the postsynaptic neuron communicating with the presynaptic saying, hey, you're in psychopharmacology with Professor Collado, you need to learn this stuff, create more connections, right? Create more receptors. Volume neurotransmission. There might be parts of the brain that don't have a lot of reuptake pumps, so therefore the neurotransmitter is going to stay in the cleft and actually travel to a further receptor, right? Think of like a cell phone. Any questions for that? Those are the main three: anterograde, retrograde, and volume neurotransmission. All right. Targets of psychotropic medication. All right. Just know the general categories. So these are just how we classify them. We have 12 transmembrane region transport proteins, right? An example I used before was SSRIs, right? SNRIs, effexor. These work on 12, it's called 12 transmembrane because there happens to be a protein that goes in and out 12 times, right? Don't ask me why, that's how they named it, all right? So you have 12 transmembrane region transporter proteins. Examples are SSRIs and SNRIs. There's a few more, but we'll keep it simple. G protein link receptors. Examples might be um, some antidepressants, some atypical antipsychotics, right, are G protein linked. And that goes through the first, second, third, fourth, fifth, sixth, right, messenger system, which takes a little bit longer to work, right? You have enzymes. I talked about monoamine oxidase inhibitors. So if it works on enzymes and you inhibit that enzyme of monoamine oxidase, which eats up neurotransmitters, what's going to happen? You're actually going to have an increase of neurotransmitters in the cleft, right? Sometimes we can treat depression by increasing serotonin. How can we increase serotonin? We can either block the reuptake so it doesn't go back inside the presynaptic neuron, right? Or I can stop the enzyme that eats it up and therefore there will be more, okay? Monoamine oxidase inhibitors, example of enzymes. Another example would be, which we don't really treat in psychiatry, but acetylcholinesterase inhibitors, right, for Alzheimer's dementia, right? That stops acetylcholinesterase, which eats up acetylcholine. Therefore, there will be more acetylcholine in the cleft, and in theory, it should increase cognition, right, or at least not degrade it. Ligand-gated ion channels, all right? Ligand-gated ion channels could be anticonvulsants, all right? Could be mood stabilizers, and you have voltage-gated ion channels, which are the same things, all right? So voltage means that if there's a change in the membrane potential, then it might open up or it might close. All right. An example for that, like I said, are mood stabilizers or anticonvulsant medications. Any questions? Do I need to repeat anything? You guys need more examples or need me to explain it anymore? No? Okay. The reason why this is practically important, because if a patient asks you, but they might not, who knows, maybe they're educated patients, right? I do have some professionals as patients, they might ask me, hey, I read about this G protein like medication. Like what does it do? I can say, well, G protein link just means that, the medication has to go through a cascade. It might, in practical terms, clinical terms, it might take longer to work, right? So, like I mentioned, an example of G protein link coupled receptor medications would be antipsychotics. Do antipsychotics work in 30 minutes? Like giving someone a Xanax? No, it doesn't, right? Xanax works on chloride channels, right? Those are ligand gated channels, which will increase chloride to go inside the cell. Therefore, it's going to cause a decrease in the action potential, right? Which in theory would help with seizures and also help with anxiety. So therefore, since it works on that channel, ligand gated channels work pretty quickly, right? Sometimes 15 minutes, sometimes 30 minutes, all right? If a medication was a G protein linked medication, like an antipsychotic, that could take weeks to happen, all right? Because it has to go through the messenger protein system, right? That cascade that they talk about in the book. So you might tell the patient, hey, it's a G protein linked medication. Don't expect it to work for, I don't know, 2 to 4, maybe 4 to 6 weeks. All right. Any questions for that? No? How do neurons adapt to medications? All right. These are very important concepts, and I'm going to keep drilling this over and over again because this sometimes explains tolerance. It also explains tachyphylaxis. Anyone know what tachyphylaxis means? What is tachyphylaxis? Tachyphylaxis means that a medication stops working, right? It's called medication poop out. So sometimes people will be on medications for a while, weeks, months, years. And for whatever reason, if they're taking it as prescribed, it just stops working, right? It's called tachyphylaxis. Sometimes it could be from upregulation, downregulation. Sometimes it could be from sensitization, desensitization, right? So think about an example would be of upregulation or downregulation. Okay, upregulation means that there's going to be an increase of the receptor postsynaptic, right? So when would that happen? What would be happening with the presynaptic neuron? When I talk about how neurons adapt, I'm talking about how does the postsynaptic neuron adapt to the presynaptic neuron. So a postsynaptic neuron is upregulating. What do you think is happening? Why would it be upregulating its receptors? You're giving someone an agonist or antagonist at the postsynaptic neuron.
Antagonist?
Exactly, right? So you're giving someone, I don't know, Haldol, right? Classical D2 antagonist for schizophrenia or psychosis. After a while, that postsynaptic neuron is actually going to start upregulating receptors, right? Because it's so used to the hyperdopaminergic state from the psychosis or from the mania that once you give a medication that's blocking that receptor, it's going to upregulate, right? Usually upregulate and sensitization, becoming more sensitive, go hand in hand, all right? So what's going to happen is those receptors are going to upregulate because you have an antagonist on board because it's so used to that innervation by all that dopamine. And whatever receptors are not covered by the antagonist are actually going to be very sensitive to dopamine. All right. So you give someone an antagonist, postsynaptic, that postsynaptic neuron is actually going to upregulate in the receptors and become more sensitive. All right. The opposite, you're giving someone an agonist. What's an example of an agonist medication in psychiatry?
Methadone.
Yeah, well, you could give someone, yeah, exactly. Opioid agonist. Yep, that's an example. Very good, right? So if you give someone an agonist, whether it's methadone, opioid agonist, right, or giving someone, I don't know, a dopamine agonist for, ADHD off-label, using amantadine, Symmetrol, or using it for Parkinson's, right? What's going to happen to that postsynaptic neuron? It's going to actually downregulate because it's being flooded with an agonist, and then all of a sudden it's going to have to what? Because we talked about excitotoxicity before. It's going to start decreasing the amount of receptors at the postsynaptic neuron, right? And those receptors that are there are actually going to desensitize, not be as sensitive. All right, let me repeat it again. You give someone an antagonist at the postsynaptic neuron, those receptors at the postsynaptic neuron are going to upregulate and become very sensitive, right? Because it's used to being flooded by a neurotransmitter. You give someone an agonist and it becomes, I'm sorry, desensitized, not sensitive, and it downregulates and removes receptors, all right, to protect itself. Again, it goes back to that concept that I was talking about called homeostasis. All right, any questions? Sounds like a simple concept, but I will ask you in exams, why do you think a patient is experiencing this symptom from a medication, right? The answer might be, well, because they're getting, dopamine agonists and therefore, their receptors have downregulated, right? Or have become desensitized. That's why sometimes, even though we don't use them as much now, we do something called drug holidays. I'm not a big fan of it, but some older psychiatrists and NPs do it. It's called drug holidays. It means that you stop the medication for a while, and then it helps the receptors go back to the way they were. All right, gives them a time to kind of go back to homeostasis. All right. There's a book called Dopamine Nation. Have you guys heard about it before? Dopamine Nation. It's a pretty good
Yeah,
book.
I read that book actually.
Okay.
Yeah.
Tell me about it. What does it talk about?
Or actually, you know what? I'm thinking of Dopamine, the Molecule of More. That's the one I read. Uh,
Well, so Dopamine Nation, just to kind of summarize it, means that people are having an increased risk of anhedonia, maybe depression, because, we're being, our sensory system is being overwhelmed with social media, right? Ads everywhere. Our body is not used to all this extracellular or whatever it is. We're not used to, going in social media, right? Our dopamine receptors are being flooded. Whenever you swipe left or swipe right, or every time someone likes your picture or you like someone's picture, right? Obviously, that's your brain is adapting to that, right? So it's increasing dopamine, which feels good, and therefore what's going to happen to that receptor? It's going to downregulate, right? The best example is you know the person who has no legs sees the person riding a bike and says, oh, I wish I had that, right? The person riding a bike sees the person on the car, oh, I wish I had that. Person in the car sees someone in a Ferrari, I wish I had the Ferrari. The person in the Ferrari sees someone in a helicopter, and it keeps going. You're never really satisfied, right? Because your receptors are kind of being you know flooded and they're downregulated. All right. Any questions with that? Agonist spectrum. Okay. So the spectrum means that we have different classes of meds that work as full agonists. So when I say agonist, I mean full agonist. All right. I can say either way. Full agonist means it mimics the natural neurotransmitter in your body. So if you're giving someone a medication for ADHD, right, which sometimes could be a dysfunction in dopamine in your brain, in your frontal lobe specifically, you might give a medication that simulates, I don't know, a dopamine agonist, right? Your body's regular neurotransmitter. Give someone a partial agonist, it's not going to innervate it the same way that an agonist does, but it might do it just a little bit, right? Sometimes we call those stabilizers. So we do have a class of meds called D2 partial agonists. When we talk about schizophrenia, which is actually my specialty, I'm really going to drill down antipsychotic medication to you guys, how to prescribe it, because we use it in many different illnesses. And, it's one of the most complicated to prescribe because they have many different mechanisms. So if I can get you guys to kind of understand how antipsychotics work in bipolar disorder or in schizophrenia, everything else will come easier. All right, guarantee it. Antagonist. All right, antagonist means that maybe there's too much dopamine in psychosis. Someone's, I don't know, using substance abuse, and you have to give them naltrexone, right? It was opioid antagonist because you don't want them to overdose on the opioids again. Inverse agonist is only a few of them in psychiatry, but there are but inverse agonist, clozapine is an inverse agonist, and pimavanserin, which is a 5-HT2A inverse agonist, which we use in Parkinson's psychosis. All right, those are the two main inverse agonists. So an inverse agonist, if I asked you in the test question, what's an inverse agonist? It actually will stop the action of that neurotransmitter. So even if you give someone an antagonist, there's something called intrinsic activity that happens, right? Intrinsic activity means that there's still going to be activity in that postsynaptic neuron just for it to function, whether it's maintaining the receptor site, keeping the cell membrane functioning, right? It has something called intrinsic activity. When you give someone an inverse agonist, that intrinsic activity actually shuts down. All right. And in the book, it also mentions giving someone an inverse agonist, it actually does the opposite what an agonist does. All right. So an antagonist blocks the receptor, but there's still intrinsic activity happening. So that means there's still a little cascade. If you look at the Stahl book, it talks about the messenger system. There's not going to be that many of them, but there's still a small amount of the second, third, fourth messenger system working, right? That's to maintain that postsynaptic neuron still working. Give someone an inverse agonist at the receptor site, it would actually shut down that intrinsic activity. All right. In research, it might have implications. Right now in clinical practice. We don't really utilize that. Like I said, there are some examples, but it's unclear if inverse agonism is actually what's causing the pharmacological effect of those medications. All right, we'll talk about that in detail when we get to that subject. All right, agonist mimics the body's natural neurotransmitter. Partial agonist is a stabilizer. So the reason why partial agonists are actually sometimes called third generation antipsychotics or third generation mood stabilizers is because if someone has too much dopamine, right, and they're psychotic or the manic, the partial agonist is actually going to work as a net antagonist, right? That's important. If someone has too much stimulation of whatever neurotransmitter, I'll just use dopamine because it's simpler, it's going to work as a net antagonist, right? So might work with mania, it might work with psychosis, all right? Someone who's depressed might not have enough dopamine in a specific part of their brain. So you give them a partial agonist, it's going to work as a net agonist. So it's going to increase dopamine, right? That's why it's called the stabilizer. So I'll say that again. In the part of the brain at the postsynaptic neuron that's being flooded with a specific neurotransmitter, let's say dopamine, you give them one a dopamine partial agonist like aripiprazole or Abilify, that Abilify in the part of the brain that's being flooded with dopamine is going to work as a net antagonist, all right? Because the affinity at that postsynaptic receptor is stronger for the medication, therefore the body's natural dopamine is not going to bounce it off, right? So it's going to work as a net antagonist. In the part of the brain, let's say someone is depressed, has anhedonia, has low motivation, because they're depressed, you give them a partial agonist, in the reward center of the brain, it might actually increase dopamine a little bit and give them pleasure. All right. So it works both ways. That's why sometimes we like to use that medication because it's like a jack of all trades. It can kind of help where there's not enough, and it can also help when there's too much. Okay. An antagonist, sometimes for maintenance therapy, right? Especially opioid use disorder, we use antagonists. Sometimes for schizophrenia, we use antagonists, right? There's a new class of medications that, hopefully will clear FDA, but it will be the first antipsychotic medications that are actually not, antagonists. But we'll talk about that when we go to schizophrenia. Any questions? Okay, so the spectrum going from agonist all the way to inverse agonist. All right, make sure you know that. Dopamine pathways, right? This is very important. So there's five of them, but we're gonna focus on four right now. Mesolimbic pathway, all right? Mesolimbic pathway is implicated in psychosis, all right? So it's the ventral tegmental area going to nucleus accumbens, all right? So in the mesolimbic area of dopamine, right, there's too much dopamine in schizophrenia. I'm gonna touch this on this again when we talk about psychosis. So therefore, what kind of medication would I want to give somebody in the mesolimbic area? Anyone know? I can give them two classes. I can give them partial agonists, right? Or I can give them antagonists, right? In the nigrostriatal dopamine pathway, that's actually the pathway that's implicated in movement, all right? Mesocortical pathway is implicated in cognition or negative symptoms of schizophrenia, and you have the tuberoinfundibular pathway, which actually is connected to prolactin, right? The reason why I really drill this down with dopamine, because I'm going to use this as an example as to why our medications have a lot of side effects. All right. So let's say in schizophrenia, in the mesolimbic pathway, there's a hyperdopaminergic state, right? A state in which someone has too much dopamine, therefore they're psychotic. In the mesocortical area, there's actually not enough dopamine. That's why sometimes patients who have schizophrenia or psychosis, they have a flat affect, right? They're not smiling, they're not happy. There's just no emotion there, right? They might have cognitive issues and complain about ADHD symptoms. They might have issues organizing themselves because they have dysfunction in the cortical pathway. And the nigrostriatal pathway, that's not really affected in schizophrenia. But if you give someone an antipsychotic medication, it affects all those pathways, right? So, for example, I give someone haloperidol, which is a D2 antagonist, all right? So in the mesolimbic pathway, that's fine because in that pathway, it's blocking dopamine. But what happens if you block dopamine too much in the nigrostriatal pathway? You need dopamine there for movement, right? Fine motor movements, me moving my arms. So people might have Parkinsonism, right? They might have cognitive rigidity, where I bend their arm and it gets very stiff. And what happens in the mesocortical pathway? Like I said, you need dopamine there. If it's already low from schizophrenia, you give them a dopamine blocker, you can have something called drug-induced negative symptoms, which actually makes it worse. So sometimes people with first-generation antipsychotics, they're actually going to have worsening negative symptoms, right? And sometimes you want to know what the baseline is because you want to know, is it my medication causing that? I might have to go down in dosing, right? And the tuberoinfundibular pathway, which has to do with prolactin, there's an inverse relationship with dopamine and prolactin. All right. So what happens if you block dopamine? There's an inverse relation. Prolactin levels actually go up. All right. There's a side effect called hyperprolactinemia if you give someone a strong D2 blocker. Right. So what happens is if someone develops hyperprolactinemia, females might have amenorrhea, right? They stop their period. They might have, you know, um, poor libido. They might be unable to get pregnant, right? They might, in long term, they might get osteoporosis, right? They might also be prone to develop something called a prolactinoma, which is a non-cancerous tumor, and that might have to be treated by a neurologist, either through surgery or through dopamine agonist therapy, right? See what I'm saying? So the reason why our meds have a lot of side effects is because we really just want to give someone a medication that's going to work in one part of the brain. But since when we take a medication through our stomach, it's going to disperse through the blood-brain barrier and affect all those different pathways. It can cause side effects. All right. So that's why you explain to a patient, my psychosis is better, but now I have sexual dysfunction. All right. Let's do a prolactin level for a male. Your prolactin level is elevated. No wonder you have sexual dysfunction. I'm growing my breasts for a male. It's getting bigger. What's going now? I'm lactating. All right. Let's do a prolactin level. It's probably from the inverse relationship of dopamine and prolactin. Therefore, you have that, right? Now I have ADHD symptoms. What happened? Well, maybe the dopamine blocker is too high. It's blocking dopamine in your mesocortical area. All right. Now I can't play basketball because I'm very clumsy and I feel like my arms are getting stuck when I'm dribbling the ball. Oh, maybe I went too high on your dopamine antagonist, right? And now we need to give you a partial agonist to help in that pathway to give you some dopamine. Does that make sense? Okay. Same in regular medicine, right? You give someone a medication, I don't know, you give someone Motrin, right? It's inhibits prostaglandins. Prostaglandins are implicated in pain, but what happens if, inhibits prostaglandin in your stomach, right? Your prostaglandin in your stomach or what secrete mucus, right? Which lines your stomach. So therefore, the patient might have, irritation of their stomach, right? Even though you just wanted to treat a headache with Motrin, you're prescribing the Motrin, or they're taking Motrin over the counter, now they're having GI bleed, right? Because it's inhibiting prostaglandins and therefore, so I mean, this works in all parts of medicine, but I'm just really focusing on, psych right now. Any questions? No? Very good. Pharmacokinetics versus pharmacodynamics. All right. Pharmacokinetics, I'm really going to focus on because I think it's very important. Because there's a lot of pharmacokinetic interactions with our medications. All right. Absorption, you guys know that, right? How is it absorbed? Distribution, or how is it distributed to the body? Is it fat soluble? Metabolism, right? What CYP enzyme is metabolizing it? And excretion, all right? How is it excreted? How is it made water soluble for the kidneys to excrete it, all right? CYP drug interactions, all right? Inhibitors, inducers, rapid metabolism. I'm sure you guys know that already from practicing FNPs, but I really just want to emphasize it in psychiatry because, the stakes are a little higher when you're working on the brain, right? Because side effects could be a lot worse. Pharmacodynamics is what receptor does it innervate, right? Or what receptor does it block? Is it a D2 antagonist? Is it a 5-HT2A antagonist, right? Is it a 5-HT3 antagonist? So eventually, you guys are going to learn the language of psychopharmacology. So if I told you there's a medication that's coming out, it's a 5-HT2A antagonist, it's a D2 antagonist, it's acetylcholine antagonist, it's an antihistamine, right? So you should know antihistamine, sedation, right? Weight gain. They might be groggy in the morning, but it might help with sleep. It's a D2 antagonist. It might work with psychosis or mania, but it might cause sexual dysfunction, right? Because it might elevate prolactin. 5-HT2A antagonist, that usually helps with side effects of antipsychotic medication. It might help with depression, right? So by me telling you the pharmacodynamics of a medication, you should already understand, okay, what could be potential side effects, all right? Pharmacokinetics, which CYP enzyme is metabolizing that medication, all right? So the CYP enzymes in psychiatry that really we focus on a lot are 2D6. All right, 2D6 metabolize a lot of our psychiatric medication, but 3A4 does also, right? 3A4s could be benzos, right? You know, 3A4s with you guys are, statins are 3A4.
Adderall, right?
I'm sorry?
Adderall. I'm sorry, Adderall. It's 3A4, right?
Yes, correct. Yep, yep. So 3A4 is without, so, just understand what are 3A4 inhibitors, all right? Chamomile tea, inducers, St. John's wort, right? Carbamazepine, Dilantin, phenobarbital. Someone is a rapid metabolizer, that means genetically they're already metabolizing the meds faster. Someone's a slow metabolizer, therefore you give them a little dose of medication, but they're, I don't know, 3, 4 slow metabolizer, and you give them a statin, all of a sudden they have side effects from it, right? Or whatever, Adderall, they have side effects from it, all right? So we're gonna focus on a lot of this stuff, as the semester goes on, but you should have a general understanding if you guys are already practicing. All right. So now it's question and answer, my favorite part. Anything that you guys read that wasn't clear? I mean, anything I can answer?
Sorry, I'm Randy. I have a question. So this isn't about the lecture. This is like about the course itself. Are we going to have the slides that you're showing? Are we going to be able to print those out to take notes on? Like, are they up? I didn't see them uploaded. I could have missed it, but
No, I didn't. I'm gonna upload them today.
okay,
I'm gonna
sorry.
upload the recording today, and I'll probably upload the slides by today too.
Okay,
Yeah.
thank you. And then well, I'll wait until you're done because I think I might have missed the sign-in thing. I checked everywhere. I didn't see where I was supposed to sign in on Monday when the class started.
It should have been on Brightspace.
Station.
Any of the students were able to do it. It's if you go on Brightspace, it's on there.
Yeah, I'm on Brightspace. I just didn't see where I need to write my name like the way that we did for the other course, the attestation. I don't know. I didn't see it.
I don't know. Anyone did it and can explain to her? Sorry, because I see.
I'm so sorry. I just want to be on
Yeah.
top of things.
Yeah, I did it. I clicked the link and it didn't even, I was expecting it to open up a different program for the lockdown responders browser because it's done that in the past when I've used it. I was able to just do it through Brightspace. I think it
Okay.
was on my normal thing.
I'll look again.
It was like
Sorry.
10 questions, true or false. Yeah.
Oh, okay.
It took like 2 minutes. Yeah.
Thank you.
Yeah, should try it again. I mean, if there's any issues, just let me know.
I will. Yeah, I'll email you. Thank you.
Of course, no problem.
I think that's it.
I know there's a lot of readings and there's a lot of material, but you can get through it. But
Could we talk about synaptic plasticity as I saw that in like weekly objectives and
yeah. The synaptic plasticity has to do with upregulation, downregulation,
Mhm.
sensitization, desensitization. That's really, synaptic plasticity. If you understand those concepts, downregulation, upregulation, that's pretty much it in a nutshell. And also, obviously, synaptic plasticity means that it always changes, right? Because that concept of if you don't use it, you lose it, or if you use it, it grows, right? That's pretty much what it is. That's why psychotherapy is very important because you give someone I tell patients this all the time, right? I can give you a medication and it's gonna protrude this pathway of your brain, but once you stop the medication, that pathway stops working the way the meds does, and you can go back, right? At least with psychotherapy, you're practicing skills, and whether it's I don't know CBT for depression or ERP for PTSD or OCD, since you're practicing those skills, you don't have to take the medicine; it's kind of reinforcing it, right? Pills don't teach skills. That's what I tell patients. So it's a combination of both. So that's also part of synaptic plasticity. Right? The medications will change the plasticity of your brain, but so will psychotherapy and interactions, right? Adverse childhood experiences, right? Kids who get abused at a young age, or adults in, I don't know, have PTSD from being in war, or veterans, right? That causes plasticity changes too. And sometimes those changes actually don't really go back, right? As you get older, your brain kind of stays in place. And what we can do is we can form new pathways to kind of override that pathway. But that pathway is always going to be there, and you could still be triggered by whatever trauma that you have, right? It's not as intense as it was before you were in therapy because we're developing other pathways to kind of counteract it, right? If that makes sense. You can think about it. There's no rush. I'm here till 1 o'clock, so.
I have a question on just something that you mentioned earlier about how I think you said you weren't a fan of, or the idea of taking a drug holiday.
Mhm.
So I'm a practicing midwife, and so I don't necessarily do psych, but I see there's no one in my area doing perinatal mental health, so I've kind of ended up trying to piece things together. And one of the
Awesome. By
reasons
the way, I run a perinatal psychiatry program.
you do,
I do run one, yes. Yeah.
oh, that's so awesome.
Yeah,
That's
in Flushing. Yeah, yeah, I oversee that program. Yeah. So yeah, so
okay.
sorry. So it's great. You're a midwife. Awesome. So when you graduate, maybe I'll hire you. We're definitely looking for perinatal psychiatrists and perinatal nurse practitioners. Yeah. We have two.
Well,
Yeah.
there's no one up in the Adirondacks, which is where I am.
Oh
So
wow. Okay.
I'm gonna
Yeah.
probably stay up here and try to do something. But
Let me paraphrase what I said though. I don't believe in drug holidays in psychiatry. Right. I can only speak for my specialty, but I don't know how that works in, where you work as a midwife or anyone else's, and the reason why I say that is because we used to do a lot of drug holidays for ADHD medication, right? But we look at ADHD as not just a school-based disorder because people have ADHD are prone to accidents, right? They drive faster, they can get tickets, early teen pregnancy, experimenting with other medications. So it's kind of like me wearing glasses, right? Or anyone who wears glasses, you wear glasses. Like, would I take off my glasses when I'm doing other things? Maybe when I take a shower, right? But like for the most part, it's a lifelong disorder. So it's kind of like you get used to having 20/20 vision when your glasses or corrective lens is on, and then you take it off and your brain kind of goes up and down. Now, again, tachyphylaxis, when it comes to, I don't know, psychosis, drug holiday psychosis, what happens is the brain develops kind of like a tolerance to antipsychotic medications. Therefore, you might need to go back on a higher dose of medication. What I do is, of course, it's shared decision making, right? SDM, which I talk to the patients. Look, I'm just, your guide. It's really up to you at the end of the day. You're the captain of the ship. If you want to stop the drugs or if you want to stop the drugs for your kids, sure. But I just want to let you know that I can only give you the risks and benefits of that. Sure. The benefits are that they might have less weight gain, right? Or less sexual side effects or whatever it is that the risks are that if they restart the med, the brain might develop a tolerance. They might have to put you on a higher dose or even change classes of medications. The reason why that's dangerous in schizophrenia or psychosis is after someone fails two adequate trials of antipsychotic medication, we have to put them on a medication called clozapine, which tends to have more drug monitoring, right? It has, severe neutropenia, which could be, could kill somebody, agranulocytosis, right? Myocarditis. So I don't really want you to develop a tolerance to the milder quote unquote medications through drug holidays. Therefore, I would rather you stay on a low dose maintenance therapy. All right. That's the reason why. Even with like antidepressants. So there are some psychiatrists that say, hey, we should treat depression kind of like we treat a cold, right? Like antibiotics. You get it. No, you get sick, we give you antibiotics, goes away, we stop. The downside to that is sometimes people do develop tolerance to the meds, and now you give someone who's doing so well on because I do have patients who I've been treating for like 5 years on Prozac, low dose, right? They don't have sexual side effects, they don't have the flattening, it's low enough that they're still functioning, and they don't want to risk it, right? Of going back to that depression. So they stay on a low dose. What happens if they stop that Prozac and they restart it again? I might have to go to 20 milligrams of Prozac now or 30. And now they have sexual side effects, right? I mean, so again, it's really up to them, but I just state the literature, what the evidence is. Again, if they want to do like the antibiotic route, go on it once in a while. Some people can get, because I mean, a lot of the illnesses in psychiatry are heterogeneous, right? Which means that we don't really know the exact cause. Therefore, it could be very different illnesses in the brain causing the same manifestation, right? Kind of like, I don't know, a sneeze, right? How many illnesses cause a sneeze? We just see the end product of a sneeze. Is it allergies, right? Is it a cold? Is it many things? Are we going to treat it with the same medication? Probably not. Maybe that's why some people respond to specific psychiatric medication. But unfortunately, our technology hasn't caught up to that yet. So I can't send someone for blood tests to say, hey, you are an SSRI responsive depressed patient. So therefore you will do well on this, right? Or you're a Wellbutrin responsive patient. Therefore you would do this. There are some genetic testing they've done, which is, if you order genetic panels, which I do sometimes with some patients, which they use, it's called the SLC 6A4 drug test, which actually measures your serotonin transport. So someone might inherit a long gene or a short gene from their mom or their dad, right? There was some evidence before that if someone inherited a short, they might be more sensitive to SSRI medication because a short gene means that you don't have a lot of serotonin transport pumps, right? But that was further not validated through when someone had from a different ethnic background, right? So different ethnic backgrounds might validate that test, different ethnic backgrounds might not. So right now, I can't say, hey, if you're Caucasian or if you're Asian, we just have to kind of, if someone wants to do it, sure, we'll do it, but it's not conclusive at this point. Right. Sorry, I hope I answered your question. I know I gave a lot of details in there, but I like to give you your money's worth.
No, thank you. That was helpful.
Yeah, in perinatal psych, we tend to use a lot of Zoloft for depression. So the perinatal psychiatry program that I oversee is it's for bipolar disorder and MDD. Right, so patients who are about to give birth, who have given birth, and they suffer from a mood disorder, where it's MDD depression or bipolar depression or mania. So obviously, the meds that we have to use have to have a very low RID, relative infant dose, right? It doesn't cross over. So it's really up to the family. There's not many stuff, as it's unethical to study, patients. So everything is just retrospective studies, right? If someone happened to be on the med and they were pregnant, we're going to use that data. But and there's certain meds that we know, like Depakote, which is definitely teratogenic, that we don't use that, right? That's like a chemotherapy agent. It'll cause, spina bifida, cognitive issues, mental retardation in the kids. So we definitely don't want to use that medication.
Yeah, I think, one of the issues I run into up here is that I have a lot of women coming into pregnancy with like a whole slew of mental health diagnoses from different providers over the years. And they're on a bunch of medications and they either take themselves off the medication as soon as they find out they're pregnant, or whoever they've been seeing isn't comfortable with pregnant people and so just tells them it's safer to stop taking. And then I feel like I spend the whole pregnancy trying to clean up messes and help get people stable as they go into the postpartum period.
Yeah, it is difficult. The only thing I want to avoid with those patients, I call it double jeopardy. Double jeopardy means that someone has an uncontrolled mental health issue where it's depression, it's not controlled, right? Or bipolar disorder is not controlled. And they're on a subtherapeutic dose of a medication because the prescriber's like, I'm afraid they're pregnant. I don't want to get, but you're not doing anything. You're still putting them at risk for the side effect of the medication, and you're not treating their mental health issue. So they have the worst part of both parts, right? So if you're
Right.
going to go all in, you might as well give some, like I tell a patient, look, if you want to be on medication, we should adjust it to get most of your symptoms under control. All right. Because then you're going to be in double jeopardy, right? The risk factors of suicide or, uncontrolled anxiety, which can cause stress to the fetus, plus the side effect of the medication that you're on. So we just want to avoid that. So I usually give them the patient, and most patients are pretty, they're reasonable. They understand. Good question, though. Please ask me. This course used to not be lectured. So like before Stony Brook students, like I've been teaching this course for about 2 years now. Before this, it was learn at your own pace. Email the professor if you have any questions. There was no like, for me, when they told me to teach it, I'm like, I'm going to teach it the right way, right? Because I want you guys to understand it and we can have very high level conversation about it, right? There might be some questions you ask me, I don't know the answer, and I'll tell you, I don't know, but I'll find out for you, all right? But it's good to learn this way because I feel like the field is being flooded by a lot of these, diploma mill schools, quote unquote, and when they're having students come out that are unprepared to practice. So, I'm kind of giving back and trying to make sure whoever graduates or at least took my psychopharm class is going to do a good job out there, right? Because there really is a need for, proficient mental health providers.
Regarding like neurotransmission, the first messengers seem like more accessible to me than the second messenger systems, I guess. What do we need to know, or what should we know about second messenger systems?
So I'm not really going to ask you about kinases and phosphokinases and all that stuff, but I do want you to kind of understand the general part of it. If you were doing the 16-week course, then I probably would expect you to, but it's only 8 weeks, I'll be reasonable. But just understand that the messenger system takes longer for it to work. So therefore, if someone's given a medication, they have to keep taking that medication constantly for those, messenger systems to continue going to cause the changes, right? Like giving someone Xanax, which is works on ligand gated channels, which work quickly. That's fine. You can take that as needed as a PRN, but you can't really give someone antipsychotics PRN, right? Because it has to go through the whole messenger system for it to work. And the funny thing is sometimes people don't understand it. You give them, let's say someone's psychotic in the hospital, right? You give them an antipsychotic medication, now they're calm. You're not controlling their psychosis. You're just sedating them, you give them neurolepsis. So they're still psychotic, but they might be asleep or sedated, right? So really it's just the antihistamine that's working there. But they're still having hallucinations. And it's ordered from they have to keep taking it every day. Because sometimes family members are like, oh, you gave them this medication, now they're calmer, they're not agitated, but they're still having psychosis. So they need to take that medication to get that mesolimbic area to be calmed down a little bit. Right. But that's just general sense. The messenger systems don't get too caught up on that. But I'm very big on CYP enzyme interactions. I really want you to know the meds of what CYP enzymes metabolize those meds. Like example, aripiprazole, right? 2D6-3A4, right? Lexapro, 2C19, right? Celexa, 2C19, right? Wellbutrin, 2D6. There are some meds that are metabolized by different CYP enzymes, but I want you to know the main CYP enzyme that metabolize. Like clozapine, right? It's a 1A2 medication. Like I said, it's a very, very dangerous medication that has to be monitored. So you have to understand that any 1A2 inhibitor, like let's say someone's on clozapine for schizophrenia, right? They've been stable on it for a while. Now they've developed a UTI. And the general practitioner says, hey, I'm going to put you on Cipro. Cipro is a very, very strong 1A2 inhibitor, right? 10 times the clozapine level. You'll kill that patient. So you need to know that, right? Please, someone is on clozapine, I tell them, please before you have meds prescribed to you, please consult with me before you take those meds. Because I've had general practitioners still give them, 1A2 inhibitors, like it's okay, but because they don't know how dangerous clozapine is, right? Unless you really specialize in schizophrenia or understand that it's a high risk medication, any inhibitor can kill that patient, right?
So
Huh?
would even like a 3-day run of Cipro for a UTI be dangerous?
Yes, very dangerous. Yeah. Unless you don't like the patient, you give him Cipro. Yeah. Antifungal meds too. Yeah, it's chamomile tea, right? People drink that all the time. Very strong inhibitor. I'll give you an example. I had a patient who was with me for treatment. She was a college student and had really bad OCD, right? We tried Prozac, we tried Zoloft, then I went high dose. I went super therapeutic also. So I was like, before I augment with an antipsychotic medication, which we do sometimes with treatment-resistant OCD, I was like, let's just try fluvoxamine, Luvox, right? Luvox is a very strong 1A2 inhibitor. All right. They're a college student. They drink about 3 to 5 cups of coffee every day. I gave them Luvox, which is a 1A2 inhibitor. Since caffeine is a 1A2 substrate, what happened? They started having really, really bad anxiety and started having panic attacks, right? If I didn't know that caffeine was a 1A2 substrate, I probably would have went up in the Luvox. So like, oh, wait a second, Luvox and SSRI, it might help you with your depression, right? Even though it's off-label, let me go all in on the Luvox. Now they're having more panic attacks. Now I put them on Xanax, right? See how the polypharmacy chain goes up? But if I would have just figured out, hey, are you drinking coffee? Coffee is a substrate of 1A2. You're on a 1A2 inhibitor. I'm going to save you some money. Buy 1 cup of coffee, you'll get the same buzz as you had on 5, right? They have 1 cup, now no longer have panic attacks. And guess what? The Luvox is also helping with their OCD. See what I'm saying? So sometimes these pharmacokinetic interactions, if you understand them, it'll save you later on from a headache, right? A lot of times what'll happen is people will come to me, and say, hey, because since I supervise a lot of people in my clinics, hey, they were seeing this prescriber. Can you please look over the medications? My patient's not getting better. I'll look at it and say, wait a second, there's a pharmacokinetic interaction. Let's stop this medication, right? Because this med might be interfering with that, and that's where they're having side effects, right? It could be as simple as stopping one med. Sometimes less is more, right? Psych has a problem. I know, I'm sorry, who was it? Who was the one working in perinatal? The midwife? I'm sorry, what was her name? Sarah? Sorry, Sarah. Hey. So
Yeah.
I'm sure you see a lot of polypharmacy, right? And polypharmacy is very big in psychiatry because the problem is people will come, well, the doctor shop, quote unquote, right? Because they're not going to get the meds that they want, so they'll go to someone else. And the person that inherits the case will say, hey, let me not stop anything because maybe it's working, right? But they never really do a good reconciliation of meds and say, hey, what does this med do for you? And why are you still staying on it, right? So then I add something, right? Then they leave me for whatever, they go to the next provider. And it's like Pokemon, they're collecting medication. It's pretty common for someone, with many diagnoses to be on like 5 or 6 medications, right? So therefore, sometimes less is more. I might reduce meds because one med might be, let's say someone is on Zoloft for OCD, right? Abilify for agitation and clonidine for, I don't know, nightmares at night, right? Now the neurologist puts them on carbamazepine for trigeminal neuralgia, right? That carbamazepine is eating up all those medications already. Sure, I can increase the doses of the medications, right? Or I can ask the neurologist, hey, can you please switch them to another medication that might be able to treat that because carbamazepine is a very strong inducer, right? It's messing up my regimen. This patient was stable. Because sometimes in psych, we don't have as many options as other people, right? Say for cardiology, right? For hypertension, you have beta blockers, you have calcium channel blockers, you have ARBs, right? You have diuretics. You have so many different class of meds that can help control the blood pressure. But for psychosis, all we really have are dopamine blockers, right? For anxiety and depression, all we have are serotonin reuptake inhibitors, right? So our leeway for switching class of meds are not as broad as other specialties. So therefore, if they have an option of switching their meds, like omeprazole, right? Omeprazole is a very strong inducer. So if someone's going to put you on omeprazole, why not use lansoprazole, right? Lansoprazole. It doesn't induce the meds, and therefore it's not going to mess up my regimen. You can switch that, and no, do a pre-authorization if you have to, but don't mess up my regimen, right? Because you have different options. I don't have an option, right? I had a nephrologist say we need to stop the lithium because the patient's GFR is going down. Well, I said, look, doc, I appreciate it, but they've been suicidal for 20 years, and the lithium is the only med that stopped them from killing themselves. So sure, I can stop the lithium. What's the alternative, right? I'm preventing them from killing themselves. What good is a kidney if the patient is dead? Right? So we have to figure out how can we preserve this person's kidney without stopping a med that has no alternatives. Lithium is the only med that stopped their suicidal thinking or thoughts, right? Or clozapine, right? There's no alternative. Someone has treatment-resistant schizophrenia and they're clozapine, unless they have severe neutropenia and their white blood cell count is about to kill them because it's so low. I'm gonna try my best, and sometimes we give them what do you call that? Colony stimulating factor, right? Because we need to keep that white blood cell count for them to stay on clozapine because it's the only med that's been able to control their psychosis, right? When they're psychotic, they try to hurt themselves. When they're psychotic, they try to kill people. See what I'm saying? So it's very important to, understand these things because we don't have many options. I'm teaching 517 also. So if when you guys go to 517, you'll see me.
I guess speaking about interactions, I remember when I was like reading the chapter in synopsis and it said something about cocaine interacting with TCAs. How concerning is that? I have so many patients who do cocaine and take trazodone.
Well, trazodone is not technically a TCA. Trazodone is actually considered a SPARI, serotonin partial agonist reuptake inhibitor.
Okay, I thought it
Yeah,
was.
SPARI. Yeah, it's not a TCA. TCAs would be like amitriptyline, nortriptyline,
Mm.
cypramine, tricycline. Yeah.
Mm. Oh, I had that in the wrong bucket in my brain.
Yeah,
Yeah.
no problem. It's okay. That's why I'm here.
Yeah.
The trazodone is interesting medication because it's depending on its dosing, it becomes a very different medication, right? So trazodone 50 is a hypnotic because it's mostly an anticholinergic antihistamine medication, right? Once you go to 150 or even above 100 milligrams, it starts to have that partial agonism at 5-HT1A, and it becomes a reuptake inhibitor. So therefore, someone will say, well, I tried trazodone, it didn't work with my depression. All right, how high did you go on the trazodone? Well, I was on 50 milligrams. That is important when people say they've had numerous trials of meds. You actually see how long were they taking. Like I had a patient say, "Well, I tried Zoloft, and it worked for me. It gave me really bad diarrhea." I'm like, "Okay, how many times I took it one time? Can we talk about that one time you took it?" Well, I also ordered Chinese food, and I had diarrhea that night. Is it possible that the sertraline? Now, every time they say that, right? Every provider writes it in the chart has tried sertraline, GI side effects, right? Because we all know that sertraline is notorious for GI side effects. But was it really an adequate trial? Right. So I really like to go whenever patients are treatment resistant, I really want to make sure they're treatment resistant, right? Tell me how you were taking it, how long you took it. Yeah, so we can actually rule out those trials. Because sometimes you don't want to give someone, ketamine if you don't have to, right? I work ketamine. Everyone's hyping up ketamine. I do see a specific population what works with people, but I worked ketamine for a year. I left that job for a reason because I wasn't seeing that many people getting as much better. Right? What's the difference of getting ketamine infusions every week as opposed to taking Zoloft every day? Does it really make a difference? And we don't know the cardiac risks of that, right? What psychedelic meds, people are talking about. Like I said, psychiatry now, people are desperate to get better, because our meds are not that great. So people are looking for different treatments. Is it really the best treatment? Who knows, right? Is psychedelics really the next wave? I'm not really sure. I've been reading about it. The risks are if someone has, schizophrenia genes in them, it could awaken it and they become psychotic. If someone has bipolarity, you can make them manic. So to give people psychedelics for depression, which might not be regular MD depression, I think is very risky. But people are desperate because they want to get better. And sometimes it takes 10 years for people to actually feel better. Right. I was actually doing a talk. So I'm a speaker for some pharmaceutical companies. So, they pay me as a consultant. So I do speaking. And I was telling them a lot of times people get misdiagnosed with MDD and it's actually bipolar disorder. And they've been putting on different classes of antidepressants, right? SSRIs, SNRIs, Wellbutrin, and they don't feel better. And because on average, it takes about 10 years for people to get an adequate diagnosis of bipolar depression. right? So people suffer, get put on different medications, and they're actually missing a diagnosis, right? And sometimes, the DSM is not the best book, right? Because it's categorical, right? Either you fit in one category. But sometimes that's not how the brain works, right? Like people will have mixed symptoms and mixed features. And is it really depression or is it more bipolar? Right? And people don't want to get put on atypical antipsychotics because quote unquote it's an antipsychotic medication, right? And it's very stigmatized. So it's challenging to get people on the right meds because, it seems better to be labeled as someone who has depression than someone who has bipolar depression is on, I don't know, Abilify, which is an antipsychotic medication, right? Or I don't know, olanzapine, antipsychotic medication. So, a lot of our job is to educate the patients, normalize it, and, try to get them to understand, that sometimes, different meds based on dosing, right? Like quetiapine is another medication, Seroquel 50 milligrams is hypnotic, Seroquel 800 milligrams is antipsychotic, Seroquel 500 milligrams is for depression, right? 200 milligrams can be used as adjunct for regular depression. So depending on the dosing, it becomes a different medication, right? How many times have I given someone Abilify as an adjunct to their depression? They look it up online. I'm not psychotic. Why do you give me an antipsychotic medication? Right? But it's technically at like, above 5 milligrams, it's more antipsychotic, right? 2 milligrams is an adjunct. So it's our job to educate them. Better than to tell them upfront than to find out later on or from someone else, right? Hey, what do you take an antipsychotic for? I thought you were depressed, right? Then they get embarrassed. Then they come back to your office yelling at you.
What should we know for serology and lab studies?
We'll focus on labs when we talk about the class of meds because I'm gonna talk about like what, yeah. But yeah, we'll talk. I don't want to confuse you guys. Yeah, but we'll talk about lab. I order a lot of labs myself. Yeah. There's so much I want to talk about, but I know the first week we're only supposed to talk about neurotransmission and neuroanatomy. I don't want to flood you guys with information, but it'll get better. It's like Lord of the Rings. The first movie was terrible, and it got better as it went up.
Is there a secret to success for learning all of this in 8 weeks?
Watch my videos. That's all I can say.
Mm-hmm.
Yeah. Watch the videos, read the book.
Yeah.
My tests are very fair. I don't ask like all these accept or select all that apply. It's very fair. But I want you guys to understand the concept, right? Because by the end of this course, I want to be comfortable that if you guys were seeing one of my loved ones, right, that I would feel comfortable you guys have a general understanding of what meds to give them, right? Because this is a foundation course, and obviously 517, 27, 37, 47, we're going to build on it. But the heavy lift is actually going to be in psychopharm now in the beginning, right? So right now it's like we're not building up. I'm making you guys max out already because then 517, 27, 37, 47 get a little bit easier. And the truth is, those classes, you don't really have access to me. Even though I'm teaching it, there's no like regular lecture. So majority of the lectures are actually being psychopharm. So take advantage of it now that you guys get to ask me questions. Because at 517, 27, I'm your professor, but there's no live lectures. You might see videos of me or, I'll respond to your stuff, but this is really where it's at. Psychopharm is probably going to be one of the most difficult classes, that you guys are going to have in your career here for Psych NP. Because again, it's a language that you have to kind of learn, right? So since I teach students too, in internship, there's some students that did clinicals with me. Actually, I did 8 students last semester, and they're all successful Psych NPs now. They graduated last week in Stony Brook. And there was a point in which I would have them treat patients, and I said, I don't want you to give me the name of the meds. I want you to tell me what class of meds and what mechanisms you're looking for, right? For example, someone has psychosis, so you would use a D2 antagonist, right? Or D2 partial agonist. Someone was given a D2 antagonist, and therefore they're developing Parkinsonism or EPS symptoms, right? So I would have to give them a second generation because it's a 5-HT2A antagonist, or 5-HT1A partial agonist, right? Someone's having insomnia, so therefore I might give them an antihistamine, anticholinergic medication, right? Or a melatonin agonist, right? Or a orexin antagonist, new class of medication. Someone has anxiety. All right, what do I need to do? I need to dull down the amygdala, which is hyperfiring, which is regulated by serotonin receptors. So therefore, I want to increase serotonin. That's why we use serotonin reuptake inhibitors, right? Someone is having flashbacks and PTSD symptoms. That's a hyper norepinephrine state, right? Because they get triggered by sounds and they were in a war, and any sound reminds them of grenades, right? So I want to give them an alpha blocker, right? Maybe prazosin to help with that. See what I'm saying? So I'm trying to link symptoms to proposed mechanisms in the brain, and that's the class of meds that I'm going to give. All right, that's probably the easiest, because at the end of the day, we don't have meds for schizophrenia, right? There's no anti-schizophrenia meds. There's no anti-bipolar meds, right? Really, there's anti-manic, psychosis, but you have to break it down even more. Like this is a hyperdopaminergic state, right? This is a low dopamine state because they have low motivation, poor concentration. Therefore, I want to balance it out, right? And sometimes it's not that easy. How patients can have psychosis and ADHD, right? So how do you block enough dopamine in the mesolimbic area and not block too much in the mesocortical area where which you're treating both symptoms, right? It can be done, but you have to understand those concepts because, hey, you have ADHD, so you have to be very careful. I don't want to give you a very high dose of the stimulant that's going to override the deep tooth blockade of the antipsychotic medication, right? Or I'm giving you a serotonin reuptake inhibitor with serotonin dulls down dopamine eventually, right? That's why it causes sexual dysfunction. Therefore, I want to give you, I don't know, Wellbutrin, right? It increases dopamine. It might balance out that depletion from the serotonin reuptake inhibitor, and we're going to balance it out. I don't want you guys to just memorize Prozac depression, Prozac anxiety. It's FDA approved for this, FDA approved for that. If you guys want to do child psychiatry, right, which I work in child psych too, 80% of our meds are prescribed off label, right? So if you were looking for FDA approved meds for kids, good luck, you're not going to find it. You're never be able to treat anybody, right? There's studied meds that have good evidence, but to get FDA approval costs money and time. And once a medicine becomes generic, farm companies don't want to pay money anymore to get the FDA approved. They can care less about it, but there's studies for it. Anyone actually do the reading or no? Be honest. I'm not judging. You guys probably didn't read the stuff.
I didn't finish it, but I'm on my way.
I hope you guys know. So
Same
at least
here.
now you appreciate why I want you to do the reading, because I want this discussion to be pretty high level. So at least I can explain it to you.
Yeah.
So, next week we're going to talk about depression. We're going to talk about SSRIs. So please do the readings and that so we can really talk about clinical cases. And I like to link, because I want it to be practical for you guys. So it's not just to memorize nonsense that you guys won't be able to apply clinically, right? So it's called functional neuroanatomy because we're actually, conceptualizing how is it going to help a patient, right? So the patient says, well, now I'm growing boobs, right? What happened? So in your brain, you're like, well, I blocked too much dopamine in the tuberoinfundibular area. Therefore, I need to give back some of that dopamine, right? By giving a partial agonist, right? Like aripiprazole, brexpiprazole, or Vraylar, cariprazine, right? That's how you should be looking at it.
And so like the things we should know for the dopamine pathways, just basically what they're associated with, like mesolimbic psychosis.
Yes, mesolimbic. Yeah, and know what track. So let's say if I ask you what is the mesolimbic area, it will be from the ventral tegmental area, which is the main cell body of dopamine, to the nucleus accumbens. All right, or ventral striatum. Right. Nigrostriatal area is substantia nigra pathway, right, to the dorsal striatum. Right. So just know what it entails. It's all in the book, but mesocortical, ventral tegmental area to dorsolateral prefrontal cortex, right?
And like regarding things that we should be memorizing, so like the SIP system and medications, and like I saw the Beers criteria was in there too.
Yeah. So no 1A2, 3A4, 2D6, 2B6, 2C9, 2C19, right? 1A2, 2B6, 2D6, 2C9, 2C19, 3A4.
Cool. How much of the Beers criteria do we have to commit to memory?
Just the psych part of it.
Okay.
Just know like the main, like definitely know, the most common, right? Like chamomile tea, right? Many people drink sleepy time tea. St. John's wort, antifungals, right? Those inhibitors. So just, stuff that you might, some antibiotics. So an example, a test question example I give you, like Prozac, right? Fluoxetine, which we'll talk about next week, but let's give you a sample, is a very strong 2D6 inhibitor. Actually, 2D6, 3A4, it inhibits a lot of enzymes, right? But I'm saying 2D6 because the medication I'm going to talk about next is a 2D6 substrate. So let's say, for instance, you give someone a beta blocker and they're on Prozac for depression, right? Now the resting heart rate is like, in the high 40s, right? And now they're having orthostatic hypotension, right? Maybe it's because you have to start that beta blocker at a much lower dose, right? Or switch to another medication, right? Because it's 2D6 and technically, I don't know, the 20 milligrams of propranolol now ends up being 60 milligrams or 40 milligrams of propranolol. See what I'm saying? And now I ask you a test question, what happened there? Right? It was an interaction, right? The Prozac is a very strong inhibitor, which has a very long half-life, which takes about 6. So the thing about Prozac, the reason why I don't like to use Prozac a lot, just so you guys know, is because it makes someone a genetic poor metabolizer. And the reason why I say that, because it's a long half-life medication. So let's say, for instance, Robert, someone gives you Prozac, right? And even though you stopped this Prozac 2 weeks ago, it stays in your system for over a month. So any meds that someone gives you, they have to give you half the dose of those meds because you had Prozac in your system and it's staying in there. So if you forget that you were on Prozac, every med that everyone gives you will probably give you side effects because you're technically a poor metabolizer for that 6 weeks that Prozac is in your system.
I give Prozac to my cat, and it's great for that reason. So if I forget to do
that's
it,
true.
if I miss a dose because I'm on vacation, it's fine. The half-life's 48 hours. Who cares, But he was aggressive towards one of our other cats, and it's been a game changer.
Now the complicated thing, which I will also is that fluoxetine gets metabolized to norfloxacin, which is the half-life over a week, right? So yes, you're right. 24 to 48 hours is the half-life of fluoxetine, but it gets metabolized to norfloxacin, which is an active metabolite, which means it actually does something. So there are some meds, which we'll talk about in detail, that are active metabolites. So their metabolite themselves would actually cause an effect also, right? Like quetiapine gets metabolized to norquetiapine, which is actually norepinephrine. I'll give you an example, right? Great example. Complicated, but you guys will understand it when the course ends. Someone was on quetiapine, right? 300 milligrams, and they were still manic. And they didn't want to take a higher dose of quetiapine for whatever reason, maybe because they were gaining weight on it, right? So the prescriber put them on carbamazepine because carbamazepine is also approved for mania, right? And you'll see that sometime. What happened is that carbamazepine, which is a strong inducer, caused the quetiapine to convert all of it became norquetiapine, which is norepinephrine reuptake. What happens is it gives someone bipolar mania an antidepressant because you're technically giving them an antidepressant. They become even more manic, and that person ends up not even sleeping. They went for like 4 days no sleep, right? What happened was if they didn't realize that carbamazepine was actually inducing the norquetiapine, they would have increased the quetiapine, which would even increase their antidepressant medication, right? Or they went even higher on the carbamazepine. It would have made them even more manic. But they could have stopped the carbamazepine and put them on Depakote instead, right? Or lithium, because there's no interaction there, and kept the quetiapine there, right? But that was a pharmacokinetic interaction that caused the pharmacodynamic interaction. See what I'm saying? The pharmacokinetic of the carbamazepine inducing the quetiapine, causing it to become an active metabolite of norquetiapine, which is an antidepressant, made the person cycle or more manic, and it was both. Does that make sense? Gets complicated, but this is the reason why, if you understand this, when you review a medication list and patient says, well, it's not working, or I don't know what's going on here, you can pick up on it, like, well, it's because of this, right? Or that. Many times patients have come to me and they say, I don't know, I just take this med down and it gave me a side effect. I said, well, that's because this med is increasing the dose of that med. Oh, my doctor never told me that. Right? And then once you establish that, the patient trusts you, that rapport is irreversible, right? Imagine like a patient comes to you and says, well, and you tell them, well, it's easy. The reason why it never worked because that med you were taking the second time was negating that first med you were taking, right? That rapport you built with that patient, right? When you told them that and then it worked after they stopped that second med, the first med started working again, is pretty much, priceless, right? Now you have a patient that trusts your expertise and they'll say, oh my God, this person's great, right? And it was simple as, just labeling a pharmacokinetic interaction.
I thought it was really interesting in the reading that paroxetine inhibits its own CYP.
Yeah, some meds do that. Yeah, I don't use paroxetine because it's a very strong anticholinergic, antihistamine, and it also has a very strong short half-life. So there's a lot of withdrawal, and it also inhibits nitric oxide, which we need nitric oxide is meant to have erection, so it kills an erection. Yeah, we do use paroxetine for people who are like hyper-sexualized and inpatient floor. So you want to kill their sex drive because you're afraid they're gonna sneak into a room and have sex with another patient. You might use Paxil, but it's kind of like unethical. But I've seen it before. But Paxil, it's still used. I mean, I get a lot of like older patients who have been on it, and of course they're doing well on it. I'm not going to change it. But for me to actually start someone on Paxil, I don't think I've ever started them on Paxil. But if they're stable on it, I'll keep it. Best advice on Friday night, get yourself a nice glass of red wine, have your loved one next to you, and watch my YouTube channel. That's the key to success. Tell your loved one, we're not gonna listen to D'Angelo today. We're not gonna listen to 90s R&B. We're gonna put Richard Collado, psychopharmacology, get the mood right. It's only 8 weeks. You can thank me after. You can always email me too, during the week. I'm pretty, the downside of being connected all the time is that, I have to respond to emails, but I'm pretty good with responding. So if you have like a question that you forgot to ask today or a concept that's not clear, if I can explain it through text, I will. If not, I'll call you. If we need to go on Zoom, it's no problem.
Is GChat 2 okay or no?
Is what?
GChat,
What's the GChat? What's that?
the Google chat for through Stony Brook, through the email.
Oh, I've actually never used that before. If you want a GChat, I mean, sure. I've never used it.
Oh, okay. I just want to make sure.
Yeah,
Thank you.
Didn't GChat come out through my email? It might be pops.
Yeah, it'll be on the left side of your panel through your email.
Oh, you could try it. Yeah, I've never used it before. Maybe students in the past have tried GChat and never responded. I wasn't aware of it, actually.
Thank you.
But email me. It's easier for me. No respond.
Honestly, I'm just like thinking of all the like long list of medications that my patients come in on and feeling like I have to go back and like go through every single one of them now to figure out, like
Listen, Sarah, if you want, obviously HIPAA compliant, don't give me the patient's name.
Yeah.
But if you want to use an example one day and just give me the list of the meds that they're on, and you can say, hey, this is what's happening, I'll be more than happy to, consult with you.
Yeah, I mean, next week I'll bring someone. I just saw this woman she was late to prenatal care for her first visit on Tuesday, and the amount of medications, I mean, she was on the ones that I can remember, Suboxone, olanzapine, Xanax. She was on, oh gosh, Wellbutrin. I mean, she it's just so many over such a long period of time.
So the Wellbutrin was probably increasing the olanzapine levels because it's an inhibitor.
Well, so what's interesting is that, so I told her, I was like, don't stop taking anything. I used the Project Teach, their psychiatric reproductive hotline, quite a bit, and went through the list, and the person that I talked to said the same thing. So then I called the person who had been prescribing her medication for years, and she was like, she didn't want to change anything. I mentioned that same thing, and she said no. So
well, the only problem is with that, sometimes people's brains do get used to a high dose of olanzapine, so you can go above. So I do levels of olanzapine. Olanzapine usually double. So if they're on 20 milligrams of olanzapine, you do a therapeutic blood level of olanzapine, it should be double that. So if they're on 20 milligrams, hit steady state, you do a level, it should be, give or take around 40 nanograms per ml, right? If they're on Wellbutrin, it probably might be a little bit higher than that. But there are studies, especially in forensics, I use high dose olanzapine in very, very aggressive patients, right? That there's studies in forensics that people have been able to tolerate olanzapine levels 150 nanograms per ml, right? That's equivalent to 75 milligrams of olanzapine a day, right? And the FDA approved one is actually only 20, right? So sometimes if the insurance companies are denying to pay for a specific medication because it's above FDA indication, I send them that study and say, look, in forensics, it's safe. Because there are some people that need a higher dose of a D2 blocker, and we'll talk about that later on. Again, like schizophrenia is my specialty, so I go to nitty-gritty about dopamine blockade and how these specific antipsychotics interplay. And I'll definitely talk about olanzapine. I like olanzapine. It's a very good medication, but it has to be prescribed, tactfully and expertly. Yeah. And really it's it's also antihistamine, anticholinergic. So if you are going to get someone off of olanzapine, I recommend a very, very slow taper over 3 months at least. Because if not, they're going to get cholinergic withdrawal, which can look like psychosis or agitation. And then you end up raising their benzo and you might not have to, right? And you might think it's a rebound psychosis, but it might not be, right?
I used to work at Bellevue, and for whatever reason at Bellevue, the psych people would never want to give olanzapine with benzos. I've Googled this and I could never really find why.
Not benzo, it's actually lorazepam. So there is a box warning.
Okay.
Yeah, lorazepam and olanzapine have caused sudden death, orthostatic hypotension. A couple of people died from it because of that. The funny thing is that warning only is for injections, but for whatever reason, the PO, that interaction is not there. But if you try to give someone IM Ativan with olanzapine, that box warning is there. And some pharmacies won't even dispense it because that happened. It could be many different reasons, right? Why their blood pressure dropped from the olanzapine. But yeah, that's the reason why. Yeah. But I have many patients on olanzapine PO and Ativan because they have catatonia. And they're on Ativan 2 milligrams 3 times a day and olanzapine 20 for the schizophrenia. And the catatonia is under control with the Ativan. Yeah. But it's because of the orthostatic hypotension that's caused death. Yeah. Yeah, olanzapine IMs though are good because the antihistamine kicks in and it sedates people. Yeah. Be careful with olanzapine PO because I know in the hospital the nurses sometimes get a stat dose of olanzapine. It doesn't peak for about 6 to 8 hours. So if someone gets olanzapine, I don't know, 5 milligrams, right? And they say patient's still agitated and give them another 5. And patient give them 10. You're not really gonna see it until 6 to 8 hours later, and the patient's just gonna bottom out and they're gonna be like sedated, snowed, right? Because be careful, the peak concentration doesn't go until later on. That's why we just do IM. It's better if you really need to get someone, under control.
Yeah, I always found it to be very effective. I was a big fan.
Me too. I would be patient all the time. Who'd you know at Bellevue? I train a bunch of NPs that work at Bellevue now.
So I actually worked in cardiology at Bellevue for 8 years.
Okay.
So I was an RN there for 7 years, and I was an NP there for 1 year. I've been working in addictions. After COVID, I was done with working in the hospital, so I was like, time to go.
Is you doing addiction now?
Yeah.
Cool. Yeah. I manage a substance abuse program too.
Cool. Yeah. No, addiction's great. I really love it.
Yeah, so you should breeze through I should have you teach the substance abuse program then. I mean the week when we talk about methadone, and I'll make sure I ask you a lot of questions because
I'm counting on that as the week I can take a vacation this summer. Or at least chill a little bit.
figure we could tag team that lecture. I can teach it. It's fine. I go another 5 minutes if you want because we did start a little late. I want to make sure you guys get your money's worth. So just ask me any questions. I've taught this class to other FNPs getting their second degree, and a lot of them have told me that learning psychopharm has actually made their regular practice of FNP actually better because since I really emphasize pharmacokinetics, even though they learned it, I think the way I was teaching it, the way it affects the brain kind of helped them. So I hope you guys have that same experience too. All right.
I have a question. For the case studies, do we pick our own groups for the case studies?
Pick your own groups.
Yeah, like pick our own, like do we choose the people that we're gonna work with on the case study, or is it just an individual work?
Individual.
Okay, all right.
There's only 8 of you. That is it. Yeah.
What are we going to be doing in NEI anyway?
The NEI, there's lectures there and there's questions, and you guys answer those too. Yeah, it's just a reinforcement of what I'm saying, you guys.
Yeah. I went to their YouTube channel a little bit, and it seemed good. Some of it seemed really the older stuff seemed kind of funky, but There's
Yeah.
some real dramatic reenactments, but
Yeah.
it's interesting.
Then yeah, it's good. Like I said, it's geared not for. It's actually not geared for nurse practitioners. It's actually geared for psychiatrists. So you're actually getting the training of psychiatry. So it's pretty good. It's not dumbed down. It's not watered down. So if you're able to understand NEI stuff, you'll be a step above.
Mhm.
It's good. Yeah, I've met Stock quite a few times actually.
Mhm.
As we're both speakers for the same company.
What company?
I don't want to say.
Okay.
I speak for a couple companies. Yeah. But you can, it's a good
Shouldn't you have to disclose that you don't have any
if it's a CME event, I do. No. Oh, one of them is AbbVie. Yeah.
Okay.
No, if it's a CME event, I have to disclose to you because I'm being. But this is not a CME, so.
Mm.
Yeah, but I do speaking maybe like once a month or so. You get free food and they pay you pretty well, so I'm not gonna complain.
My friend does that for Gilead, and actually, she comes into the place where I work and does it. It's pretty good. They buy us all lunch.
Yeah. That's one of the perks of being an NP, right? You get good food and get to eat in nice restaurants whenever you want. But the case studies, please really put a lot of effort into it because the thing is that can make it or break it. All right. There are some students that like barely because the tests are hard. I'll tell you, they're challenging. I won't say hard, I'll say challenging, but they're fair. Right. And sometimes, if you have like an 81 point, I don't know, 50, right? I can't round up. So technically you would fail the course. So, don't give up points in your case study because you overlooked something or you didn't cite something. All right. It's easy. But yeah, I'm not very strict on that stuff, but I do want you to have a general understanding of it. So don't lose points on your case study and fail the class because, you messed up on the case study. That should be an easy 10 out of 10. All right.
Just for planning purposes, for the midterm and the exam or the final, are they open? Is it open for like 24 hours or is it open for
It's
like
open for 24 hours. Yeah.
24 hours? Okay. Just for like work planning. Okay. Great.
Usually it's open the midnight the day before and to the midnight the day before. Yeah. If you're feeling really, really confident, you can take it a half hour before it closes down, 11:30 p.m. If you're feeling really confident, I'll be impressed by that if you could do it. The best time to take the midterm actually is after breakfast. Studies show that your cognition is best after breakfast, right? Assuming you're not working overnight. So don't wait until like after your shift. I have people, hey, I worked a long shift. I finished at 5 p.m. I took the final, at 6 p.m. No, that's your cognition is already down. Take a day off, relax, get a manicure, pedicure in the morning, go to European Wax Center, get that done, and then take your exam before 12 p.m. ideally, and you'll be fine. All right. And then you use Respondus, so be careful. I've had someone in Respondus, they had a picture of a person behind them, and they picked up, like I have this Bruce Lee picture here behind me. Be careful of faces. The Respondus might pick up the face as a person. So just be aware. So take down all your Britney Spears pictures, the Backstreet Boys, whatever. Don't put it behind you. Because if it picks it up as a person, it's gonna flag it. All right, just try to find like a room, no posters, no faces. All right, and also scan your eyes, so don't cheat. All right. Well, very nice to meet you guys. All right. Reach out anytime if you have any questions. I'll see you next week. Sometimes I might have to change the times here and there, but I could be flexible with you guys. So for now, 11:30 to 1 p.m. works for me. But if I ever have to move it around, I'll definitely let you guys know ahead of time. All right. Like I said, I'm still recording it. So, but you get the most out of it if you ask questions. So I'll record it, but really try to ask questions. All right. Great first class. Nice meeting you. Have a nice day.
Thanks so much.
Take care.
Thank you.
You're welcome.
Thank you very much. Have a good weekend.
You too. Take care.